FM and online. What an absolute delight it is to join you once again on this very cold Wednesday evening, although I haven't seen a flake of snow inside all this hype about this lovely snow, this lovely white stuff that we were going to get, and I haven't seen. I'm so disappointed because I find it so pretty. So I officially complain to the meteorological office that why don't we have any snow here in Peterborough? Although I wouldn't like for you to be inconvenienced by it, because it is rather difficult getting into work and into school, and I would have much rather have seen it over the Christmas period. But it's a delight to welcome you all once again to the Body Health and Mind Show. It's been a positive week for me. Wonderful. I love the work that I do. I'm a local GP, as you know, within the city of Peterborough, and at a very busy general practice, supported by an absolutely wonderful team, and here on the radio, equally supported by an absolutely wonderful team. And before we commence this show, I want to tell you something positive. Now, it's always my intention to try and share something inspirational. And the inspiration that I share is about an individual, usually every week, and they usually get a shout out on my show. But today I want to actually tell you a little bit about this young girl. And today she is an absolute hero for me. Her name's Mariam, and she's listening to the show right now. And I want to dedicate my show to her today, and I'll tell you why. Now, Mariam is one of the bravest young girls I've ever seen. And she has recently been diagnosed with diabetes, type 1. And the courageous manner with which Mariam deals with managing her blood sugars, sometimes they go down, sometimes they go up. She can become very unwell as a result of it. And I followed her story where I've seen her go in and out of hospital many times. And I'm so admirable of her. And I want to tell you, Mariam, that you're listening on this show, and I'm so proud of you, and you are an inspiration not only to me, but to many other children your age, and I want you to know that. So my show, Mariam, today is dedicated to you. And let's all join in congratulating Mariam at being such a super girl at managing her condition. And I'm sure she'll be really happy to hear this, and she's a brave girl. So well done you, Mariam. So, after having announced that, I've got a wonderful guest today on my show. We had this guest a couple of months ago on my show, and I thought it's always nice to break the regularity of dealing with conditions that can pertain to men, women and children. Why not talk about women for a change? And I have on my show the wonderful Dr. Masroor Khalid Cheema, Mr. Masroor Khalid Cheema, because he's a surgeon. And he is MBBS, DRCOG, MRCOG, MRCPI, FCPS, DFFP. These are the designations that you have in terms of qualifications. And he's a specialist registrar in Obstetrics and Gynaecology. He's got a specialist role in advanced antenatal care, advanced labour ward management, and in Gynae-oncology and Colposcopy. And I would like to welcome him on the show. Assalamu alaikum, Mr. Khalid Cheema.
Walaikum assalam.
It's wonderful to have you back again.
That's very kind of you.
So it's nice to see you, because I remember last time we were unable to see your video. And this time we have you, and the whole of the Salaam radio can see you on Facebook, and obviously we are live on Twitter, we're live on YouTube, we're live everywhere, we're live on Periscope. So I'm sure that a lot of our listeners will be very happy to see you.
Oh, that's very kind of everyone.
Oh, so I'd like to let everybody know, first of all, that I texted Mr. Cheema on Monday, because it wasn't that I just, was thinking, racking my brains, let's do something different for a show, etc. I hadn't asked anybody to come on until that time, and I thought, okay, I'll do something different. And then Mr. Cheema came to mind, and he told me that he was actually on nights. So he was on nights last night, and he's had a rest today, and he's actually come back in action for us today. So we're very lucky to have you, I must say.
It's very kind, but ignore any black marks Black lines under the eye.
Oh, bless you. No, not at all. Can you tell the audience how many babies have you welcomed into the world last night?
I think, usually it's the midwives who do that.
Yes.
And they are the forefront of delivering babies, and the very, I would say, a workforce that we should salute them.
Of course.
Yesterday we had around 16 babies.
That's amazing. Oh, this is so lovely. Heartening to hear that 16 new lives took their first breaths.
Absolutely.
Under your governance, under your taking care of them. That's wonderful. That's wonderful, Mr. Cheema. So, as you know, today we're going to be talking a little bit about two topics mainly, sort of polycystic ovarian syndrome and also fibroids. And if any of you who are listening want to have a go at asking a question, we have the text and WhatsApp number on 07745278978, or you can ring us on the studio and telephone number 01733602133. But you're more than welcome to ask questions on the Facebook Live page. And if not, you can inbox us questions as well. So, Mr. Cheema, can we talk a little bit first about polycystic ovarian syndrome, if that's all right?
Yeah, when you texted me on Monday,
yeah,
really the reason to agree immediately, one, obviously it was you.
Thank you.
And second is that it is one of the very important topic, I would say very close to my heart.
Okay.
Because that's where a new generation is, hopefully they're listening.
Yes.
To be affected. And this is one of the things that we can, if not eradicate, we can at least control it to a certain extent, or if it is there, we can advise young girls how they can effectively improve their fertility, how they can effectively reduce the chances of developing lethal complications later on, because as you started your show talking about diabetes, so that is one of the future complication or problems associated with polycystic ovaries.
Wow. Okay, that's very interesting to hear. So,
please.
So, for our listeners' knowledge in terms of polycystic ovarian syndrome, would you like to give a bit of an overview about what it is, and probably what its pathogenesis or how it develops or what the risk factors are, please?
Basically, as a doctor, we all know, but just to inform public, every girl who's born is born with two ovaries, and these are the reproductive organs. Like in male, they are testicles, in female, they are ovaries which produce egg.
Yes.
When a female is born, it contains around 20 million eggs. When they are still in the womb, it's 20 million eggs.
Wow.
Born, they drop to 2 million, and gradually, by the time they are fertile, they retain around 400,000.
Wow.
So these are the eggs which they are going to mature through their normal cycle. So when a girl have a period, ovaries go through a working phase where they incorporate that immature eggs to go through a process to make them mature, and then hence where the fertilization and everything then happens. So rather than going into the details, ovaries play the most important role in running the human race. Now, due to certain reasons, and there is partially a genetic preponderance, but it's not very strongly linked, but environmental factors have been implicated very strongly, making these ovaries produce multiple small cysts.
Oh, okay.
By forming these cysts, what happened, the regular functioning of ovaries is stopped. So I'm just talking in very layman terms. When I say stopped, these girls stop having regular periods.
Okay.
So in technical term, we call it either oligomenorrhea, which means probably having 1 or 2 cycles in a whole year.
Okay.
On average, every woman have a period every month.
Yeah.
So in a year, they should have 11 or 12 periods.
Sure.
These girls with polycystic, they have 2, 3, 4, maximum 5 cycles.
Yeah.
They can be irregular, they can be less, or sometimes they don't have any cycles for 6 months.
Yeah.
So basically, ovaries are not working. When they are not working, they are not producing egg. So infertility becomes very common. It's very difficult for these girls to conceive.
Yeah.
That's one very common problem.
Hmm.
Secondarily, it is a very complex mechanism, and as it is said, for the present time, it is one of the most commonest androgenic or endocrine abnormality of female in the present time.
Wow. Wow. Okay. And I'd be interesting to know what the environmental factors would be that contribute towards the development of polycystic ovarian syndrome. Could you give us a little bit? You've spoken about diabetes obviously being one.
Now, polycystic ovaries, initially we thought that it's a disease of girls who are overweight. So a BMI above 25 up to 30 is called overweight, and above 30 is called obese.
Okay.
When a girl is above a BMI of 25, which is an ideal, and above that is higher,
Sure.
then they increase their chances of developing polycystic ovaries.
Okay. Okay.
Now, with more research, it is found that it is not necessarily a disease of obese patients, because 20 to 40% of women who have polycystic ovaries still can be of normal weight.
Okay.
But as we said, half of the girls are obese, or more than half of the girls are obese. So obesity has its own risk factors.
Mm-hmm.
So what happened basically in this disease, your ovaries, rather than producing normal hormones, they produce certain hormones which are also helpful in increasing the secretion of insulin, and as a result, their glucose level goes up.
Okay.
And that makes them diabetic, or they are more liable to develop diabetes in later part of life.
Okay.
So when insulin goes up, it goes into a vicious cycle.
Mm-hmm.
And one of the hormone, I mean, it's slightly difficult to explain, but the very simple mechanism for lay people, because your show is for the general public more, not only for the doctors, is to explain them that it is a triad of three things. One is abnormal periods,
Okay.
where we already said less periods
Yeah.
or absent periods.
Yeah.
Secondarily, girl produce certain feature which we call hyperandrogenic features.
Okay.
Is male pattern of hair growth, sexual hair growth, which is quite disturbing for these girls.
Yeah.
Like hair recedes on the head.
Okay.
Similarly, clitoromegaly, that
Okay.
is disturbing for them.
Okay.
All because their androgen, which is more like a male hormone,
Yeah.
their level increases in their body.
Okay. Okay. Right. That's very interesting. And in terms of obviously signs and symptoms, you've given the signs, that the three sort of cardinal signs or the more common signs, but within our own, so I'm talking of people that present first of all to their GP, would be women or young women who have started their cycles, or menarche as they call it, and they are then presenting with scanty periods that are irregular or non-existent, in some cases one after a few months. And would you then advise, as general practitioners, we should go in straight away for blood tests?
I mean, see, again, going back into, we have talked about three things. The third thing which I was going to say, because there is a consensus group called Rotterdam, which is one of the fertility association which has created that. It has three criteria to diagnose.
Okay.
First, we said abnormal or irregular or absent period. Second, we said these androgenic features, which we discussed. Third is scan finding of having at least 12 cysts,
Right.
cysts in each ovaries. So we have to have two of these features to diagnose that person as polycystic ovaries. Now, coming back to your question, yes, commonly how we come across this is mother bringing their daughter that, yes, she started having period, but then her periods are not happening for 6 months. Now, you know, in girls, it's very common, especially teenage girls who are going to school, that under stress and exam situation, moving to hostel can affect their periods.
Yeah.
Sometimes it is overkill that we immediately jump to polycystic ovary. But yes, if you see a girl who is overweight or obese, she has some facial features. They can have acne, they can have hair growth, they can have baldness, which can be seen. You can see certain features where you can immediately say, okay, they do look like with these features, but then, as we said, 20-30% of girls don't have these features. So it is pretty difficult to diagnose. But yes, if you have done the other bit, you have taken the history, girl saying, oh, I'm not having any exams, I'm generally well and fine, I'm eating, drinking okay, then yes, it's worthwhile investigating further. And organizing a scan, just an abdominal scan, is very simple to get, and then based on that, we can do further things.
Okay. Well, that sounds really interesting. Now, in primary care, just say somebody has been diagnosed with having polycystic ovarian syndrome. I've seen a lot of cases whereby girls aren't actually referred to tertiary care or to gynecologists, but they've been told by a fellow GP, for example, that this is your diagnosis. We've had some blood tests done. It looks like the male hormone that you spoke of, it's usually testosterone, is a little bit high, and you've got cysts on your ovaries. They're not yet married, but obviously would intend to have children further ahead once they get married. What can be done for such patients?
Okay. The first message from this conversation, which I would like everyone to take, is if they have daughters, watch their sugar intake.
Okay.
Advise not to eat this all fizzy drinks, sugary food, because what it does, it offsets your insulin. It offsets your general metabolic system, and then it triggers her on putting weight, which can trigger toward polycystic ovaries.
Right.
Second is, yes, polycystic and obesity or weight is risk factor. So how to reverse it? So when we get a patient in our clinic with polycystic ovary, two things are very important. As you said, people know polycystic ovary and they think, okay, they are done. There's no way out. Now they can't have babies, as you were saying.
Yeah.
Most important thing is like diabetes. When you talk to your diabetic patient, you first tell them it's a lifelong struggle.
Yes.
And it is not that you are going to win over unless you don't correct your ways of living. So you just have to alter your lifestyle. Polycystic ovary, exercise, and at least 5% of body weight reduction tremendously improve their fertility.
Wow. Okay, that's amazing. Okay.
And interestingly, I was reading, and as a surgeon, as a gynecologist, I was not aware of it, but just little bit preparation for your program, I came to know that if someone reduces 5 to 10% of body weight, it reduces 30% of fat around their viscera, which is very helpful for reducing their diabetic risk.
Yes.
So this is how it is effective. So the first thing I say to girls, yes, one issue is the facial issue.
Yeah.
You can deal hair waxing or laser, whatever they prefer, that can be done.
Yeah.
Secondarily, the most important is regular exercise, at least half an hour every day.
Okay.
Themselves more active.
Yeah.
And third is join a gym, reduce their weight by 5%. And believe me, I've seen, must share one patient which was from a very humble background.
Okay.
Sort of very broken family, and she amazed me. I saw her, like, usually we see them in 6 months or a year. We give them good time. And I couldn't recognize her.
That's amazing.
Diet plans like Cambridge or other, I didn't want to take any name, but they're very effective.
Yeah.
And the person is not. If someone is, say, 80 kg, 5% of their body weight is 4-5 kg, which is nothing.
Wow. Yes, of course it's nothing. You're right. Because, and it's all about willpower, Mr. Cheema. I mean, talking about weight, that is something that I think that it's important having these shows, because a lot of my listeners, in form of patients as well, will come to me and say, in a sort of a disappointed tone that, oh, all my GP ever tells me to do is lose weight. But actually, if you listen to what Mr. Cheema has said in this context, this is the golden nugget of information that I always give you during these shows. And this is the golden nugget of information that Mr. Cheema has given, that losing 5% of your body weight with sheer determination, willpower and persistence of half an hour on a daily basis can improve your fertility by 30%, which is a significant amount.
Absolutely.
So,
and immediately they will see, the first sign is the fertility getting better is their periods start getting regularized.
Yes, and that's a form of reassurance, because a lot of girls find it extremely worrying that they're not having regular cycles. So that's a form of reassurance as well, seeing regular cycles develop. And we've got Mr. Shaznawaz Park Ward, who is watching the show, Mr. Ansar Ali, Dr. Azhar Chaudhry, who's our local GP and a very dear colleague, and Sister Noreen B. And it's wonderful. And I'm so happy that some males are listening to this program as well. It shows that it's wonderful to have that type of reception to listen to. Now, Mr. Cheema, following on from that, weight, that's the golden nugget of information that we have, weight. And you've spoken about the other symptoms as well.
Cut down sugar. And
cut down sugar, absolutely right. So no fizzy drinks. And in fact, I think that they were talking about having a fizzy-free February. And some of the local political figures wanted to promote that. So that will be very interesting if they can promote that in the local schools. And I think that would be a good place to start, actually, a fizzy-free February. So no fizzy drinks, cut down on the intake of sugar, as Mr. Cheema has said. And if you have been diagnosed with polycystic ovarian syndrome, it's to cut down on your weight. Now, in the last 4 minutes until we reach the break, Mr. Cheema, and then we can talk about fibroids. Say you have the scenario of a woman who has established polycystic ovarian syndrome. She is married and she is struggling to conceive. There are some medications like metformin which are used off license, etc. What's the theory behind using such medications?
So basically, metformin, as you know, it's a drug used commonly in diabetes.
Yes.
So it doesn't let blood, like glucose we eat or sugar we eat, to get absorbed. Yeah. So it's excreted. Hence, your body glucose level doesn't go up.
Okay.
If glucose level doesn't go up, it doesn't trigger the release of insulin. It doesn't doesn't trigger the release of insulin. So the chances of becoming diabetic or abnormality in your hormone, which insulin causes, more androgen secretion is reduced.
Right.
So in a way, metformin is quite effective in improving the fertility. And even girls who are struggling to ovulate, as we said, weight reduction first, then we can start them on Clomid, which is ovarian stimulating medicine.
Wow, okay.
With that, they can have metformin. So there are multiple modalities. Then comes to the surgical side, where you can do ovarian drilling, which is just making little bit holes in the ovary with laparoscopy. And that trigger, it's just like jump starting their ovaries.
Wow.
So that can be done. So there are a lot of options.
Yeah.
But the main message I wanted to take is definitely weight reduction. Second, it's not end of the world.
Yeah.
They have lots of girls with us. They are polycystic ovaries. They have normal, healthy pregnancy.
Yeah.
Yes, polycystic ovaries, if they go for other IVF or other stuff or even Clomid, they have high risk of having multiple pregnancies.
Yeah.
Hyperstimulation can happen, which can be all managed.
Yeah.
Yes, they have good chances to get pregnant. So this is not end of the world.
Okay.
More worst thing is complication they can get in pregnancy, because if someone is polycystic ovary, they are high risk of developing diabetes in pregnancy.
Ah, yes, you did mention the link with diabetes before pregnancy as well, so that would go to say that yes, okay.
They should have a glucose tolerance test once they are pregnant. They are high risk for developing diabetes. Two very important things before we Rather, I would say that probably polycystic can take whole of your show. Yeah. Because the most important thing the girls need to know is that when they are not having regular periods, the lining of the womb keep on growing.
Ah, right. So what we can do is, we've got 30 seconds to go to the break. I am going to hold that, what you have said. So with irregularity of periods, listeners, Mr. Cheema has said that the lining of the uterus keeps on growing. And we are going to come exactly to that point just after the break. Do excuse my interruption, Mr. Cheema, but it's wonderful. This show is wonderful and we are having a lot of engagement on the show. So join us after the break and Mr. Cheema will enlighten us further on what happens during polycystic ovarian syndrome.
Stay tuned to Salaam Radio after this short ad break.
Third world and developing countries are home to some of the most vulnerable children on the planet. Malnutrition, severe lack of medical aid and access to clean water are just some of the horrific challenges faced by orphans across Africa and Asia. Children of Adam, a Peterborough charity, need your help to bring aid to these orphans for just £25 a month. To sponsor an orphan or assist with other projects, please call 0300 321 0032 or visit www.childrenofadam.net.
सोचिए अगर आपको NHS GP की सर्विसेज हफ्ते इतवार और रोजाना शाम को मुहैया हो। जी हाँ, अब पीटरबरा GP हब ने इसको हकीकत का रंग दे दिया है। बर्बरी मेडिकल सेंटर, क्रेग स्ट्रीट, PE1 2EJ में ये सर्विसेज मुहैया हैं और आप शाम का और वीकेंड का अपॉइंटमेंट बनवा सकते हैं। अपॉइंटमेंट बुक कराना बहुत आसान है। अपनी नॉर्मल GP सर्जरी को फोन करें और GP हब के लिए अपॉइंटमेंट बुक करवाएं। तफसीलात के लिए अपनी GP सर्जरी से रुजू करें।
Had a car accident or an accident at work? Accident specialists are experts in no-win, no-fee accident claims. Leave the hassle to us. Our multilingual settlement experts will manage the entire claims process on your behalf, with nothing to pay up front. We provide services such as credit hire, taxi vehicles, recovery, storage and much more. For full details on our range of services and a free consultation, call us on 01733 555 774 or visit our office at 249 Lincoln Road opposite the NatWest Bank. Accident specialists. Start your successful claim today.
Need a great place to chill out? Look no further than The Lounge for quality food and drinks at a great price. Try our varied menu: pasta, seafood, burgers, grills, salad, soup, rice and sides. Also hot and cold drinks, milkshakes and mocktails. Leave room for our exquisite desserts. The Lounge, 417 Lincoln Road, Peterborough. Call 01733 709 306 to order for delivery. The Lounge, friendly service with a great atmosphere.
छूटे न कभी तेरा दामन या ख्वाजा अलाउद्दीन वली, रहे तुझ पे फिदा मेरा तन मन धन या ख्वाजा अलाउद्दीन वली। आफ्ताब इल्म हिकमत मोहसिन मुल्क मिल्लत हुजूर शेखुल आलम पीर मोहम्मद अलाउद्दीन सिद्दीकी रहमतुल्लाह अलैहि और ख्वाजगान नेरिया शरीफ के हुजूर गुलहाए अकीदत पेश करने के लिए 3 फरवरी बरोज़े इतवार बादज नमाज ज़ोहर जामे मस्जिद घंगोल शरीफ में, जो कि ज़ेर सदारत जानशीन हुजूर शेखुल आलम हज़रत अल्लामा पीर डॉक्टर सुल्तानुल आरिफीन साहब मरकज़ी सजादा नशीन दरबार आलिया नेरिया शरीफ मुनक्कद हो रहा है। आप सब मुहिब्बीन, मुरीदीन और मुतवस्सिलीन से पुरजोर अपील की जाती है कि इस प्रोग्राम में शिरकत करके सवाब दारैन हासिल करें। अलावाजी पीटरबरा से मर्द और ख़वातीन के लिए अलग अलग फ्री कोचेस का एहतमाम किया गया है। मर्द हजरात इस नंबर पर राब्ता कर सकते हैं 07812 442526 और ख़वातीन इस नंबर पर राब्ता कर सकती हैं 077 11 250 953। शुक्रिया।
Peterborough's community radio station, Salaam Radio, 106.2 FM.
Assalamu alaikum. Welcome back. This is Dr. Shabina for the Body, Health and Mind Show, and we are going to get right in to talk about what we left off before. After the break, we have the wonderful Mr. Masroor Khalid Cheema, who is an obstetrician and gynaecologist, who has joined us today after his night on call last night. Thank you very much for remaining with us, Mr. Cheema. So, just to reiterate, so we were talking just before the break that once ladies who have polycystic ovarian syndrome are suffering from irregular periods, the lining of their womb or their uterus grows.
Yeah, basically every month lining of the womb grows and sheds, causing period.
Okay.
So if a woman is not having regular cycles, is not shedding that lining of womb every month, under their normal body or ovarian hormone, that lining keeps on growing. The more it grows, the more the chances it goes into a state called hyperplasia, where it's bigger than the usual cells. And that is a state which can trigger for these cells to develop cancerous changes, which is cancer of the lining of the womb, which is one of the top 5 cancers of female genital tract. So these women with polycystic ovaries, they should have at least an induced bleeding if they are not having regular period, induced bleeding every 3 to 5 months, which means if a girl comes to you and you're diagnosed to have with polycystic ovaries, so you have given her a time of a year to reduce her weight, to improve her symptoms. In that year, you should prescribe them progesterone tablets.
Okay.
Take it 10 milligrams 3 times a day for 5 days.
Okay.
Every 3 months. And this helps shedding the lining of the womb so that they keep under control, they don't overgrow.
Yeah.
You're reducing potentially the risk of developing cancer.
Wow, that's very interesting, and that's something that I wasn't aware of. It's certainly a learning curve for me that if I have patients who have polycystic ovarian syndrome, many of them actually come and say, you know, we haven't had a bleed for 6 months or whatever it is. And so your advice is to give a northisterone or progesterone only pill 1-3 times a day. Now, with regards to that, that's a very interesting question. What I'd like to ask you from a general practice point of view is that when we're looking at the younger sort of cohort of ladies, we worry about the effects of northisterone causing DVT. Would you advise Provera instead?
Okay. Interestingly, northisterone or estrogens, they are not associated with increasing the risk of DVT.
Right.
It's estrogen.
Okay.
So if you are using mini pills, we have a category called UK Medical Eligibility Criteria.
Sure.
Any GP who is prescribing any hormone should see the medical eligibility criteria. So for obesity, smokers, advanced age, your combined, which contained estrogen, progesterone, reaches UK MAC 4, which is not to be used.
Right.
The progesterone stays safe. Even a high BMI smoker, they are safe because progesterone is not associated with causing DVT. It is more of estrogen.
Right.
So just giving them progesterone, you're not increasing the risk of developing DVT. So that is very clear.
Yeah.
So you give progesterone very clearly. The only difference is that, as you're saying, the patient comes to you and saying, I'm not having any periods. The most important thing is to see whether she doesn't have already something abnormal. So getting a scan, scan shows lining of the womb is less than 7 millimeter. We take in our local hospital 5 millimeter or less, someone of 40-45 as normal. So if it is 7 or less, as based upon the recommendation from Royal College, then we are fine to give a progesterone. If it is more, it is better to take a biopsy to rule out any cancer before you give any hormonal treatment.
I understand. Okay. Well, that does definitely make sense. So we've covered quite a bit, and I'm sure that you would have loved to speak a little bit more about polycystic ovarian syndrome. Before we move on to our next topic about fibroid, was there any closing or conclusion that you would like to give with regards to this?
Yeah, closing again, the message is same. Again, weight reduction, reducing your sugar intake, whether it's basically carbohydrate intake. And two things which we haven't touched still in polycystic ovary is that these patients in their later 40s are anyway 4 times increased risk of developing type 2 diabetes.
Right.
And simultaneously, they are very increased risk of what we call it sleep apnea.
Okay. Wow.
And third is they are highly increased risk of cardiovascular problems. And in your GP, the normal assessments you use for cardiovascular risk is not applicable to these patients. So you have to see their smoking status and all that bit along with polycystic ovaries, and that makes them high risk. So it's very important for them to reduce weight. It's very important for them to have a healthy lifestyle. It's very important for them to have regular periods.
Okay.
So if they're doing these 3 things, they can have as much healthy lifestyle as anyone else.
That's wonderful. And it's a wonderful conclusion. So ladies, you've heard all of that. It's going to be fizzy-free February soon. So just as Mr. Cheema has advised, you cut down on your sugar, work that just a little bit extra hard to try and reduce weight, half an hour every day. It's not too difficult. And aim to have regular periods. So wonderful insight and overview on polycystic ovarian syndrome. I've certainly learned so much, and I'm sure that you have too. Now, moving on to our next topic about fibroids. This is also something that we deal with. Now, within my practice, Mr. Cheema, there is a high population of ethnic minority women. And would we be right in saying that fibroids are more commonly seen within Black Afro-Caribbean and Asian ethnicity females?
Yeah, African, it is predominantly very, very common.
Yes.
Generally, 20% of girls, like if 10 patients walks through your door who are female of reproductive age, 2 of them will have fibroids. So it's that common.
Right.
It's nothing that we should be saying that's a rare thing. Very first important message is they are the least commonest of I would say growths which develop cancer. The risk of developing cancer is less than 0.5% or less than 1%, you can say.
Great.
So out of 100 patients, less than 1 will develop cancer.
Okay. And would you like to give our listeners a bit of an overview? So if you give a typical scenario of a woman who's presented and she actually has fibroids, what would the expected signs and symptoms be of a woman having fibroids?
Usually the patients who present to us and have fibroid, because fibroid increases with the growing age.
Yeah.
And then after the period stop, they tend to regress a bit.
Okay.
Because the hormone effect influences their growth. There is no set etiology, but can be, as you said, it is in certain minority groups, it is more prevalent. A certain ethnic group, it's more prevalent, like in Afro-Caribbean populations, more prevalent.
Yeah.
So fibroids are basically, these are fibrous growths, as we say fibroid. So fibrous mean a tissue which cannot stretch. It's hard, and they usually grow in the womb, but they can grow outside the womb. As we are talking about fibroid of the womb has got 3 linings. So fibroids can be which are growing in the cavity of the womb, which are inside the womb, which are in the wall of the womb, or which are in the outer layer of the womb.
Okay.
Now, the fibroids which are growing in the cavity, obviously they are the one which are more problematic because they distort the cavity. They increase the risk of infertility.
Yeah.
If pregnancy, implantation, and everything gets affected, they increase the risk of heavy bleeding.
Yeah.
Because we have to, the easy way I explain to my patient is that womb is a muscle. The central major part is muscle.
Yeah.
And muscle, the fibers run like a crisscross, like my fingers are running. And in between that crisscross, like my thumb protruding out, are the vessels.
Right.
So the top layer sheds, these vessels are naked and open.
Okay.
bleeding. So that muscles, this crisscross contracts and squeeze or shut down these vessels. Now, if in that muscle there is a hard globular structure which doesn't let this muscle contract, these vessels can stay open and can continue bleeding.
Right.
Secondarily, because if this fibroid is protruding in, so increasing the surface area of the lining of the womb. So more the lining of the womb, more it sheds, more bleeding they have.
Okay.
Simultaneously, this other feature they can present is with pain.
Yes.
Muscle is trying to contract, couldn't contract, so they have more period pains.
Yeah.
Third is, so first was heavy periods.
Yeah.
Second is painful periods.
Yeah.
Third is infertility. They get pregnant, they miscarry, or they don't get pregnant.
Okay.
And the fourth most commonest is they come with, I'm feeling some mass in my tummy. Feeling dragging sensation, especially in the later part of the day. I'm doing my job in the later part of the day. I feel there is something dragging down.
Right.
And when you do a scan or you examine, you find that the womb, which is normally the size of a very small inverted pear, is more like a watermelon.
Oh, wow. Okay.
It's orange or a grapefruit size.
Yeah.
Their size range from few millimeters up to many centimeters. So they are of all shape and size. They can be hanging like a grape from the wall.
Yeah.
Pedunculated. They can be in the wall like a rock hard cricket ball.
Wow.
On the womb, even you can feel from the tummy, especially when they get pregnant, you feel, oh, this is baby, and what is this round thing at the top?
Yes, that's right. Yeah. Wow.
So they can present in many different shape and sizes. And it's not necessary that they come in, there's only one fibroid, they can be multiple, many tiny fibroids.
Yeah.
So these all are the things. But yes, heavy bleeding, painful bleeding, fertility, or dragging sensation. All that are the common presenting features with which patient will come to us.
Wow. So yes, that's quite interesting, because that is the common presentation that patients usually come to myself for, and often through an ultrasound scan you're able to diagnose. Now I do have some questions that are filtering in. Obviously there are some sisters that have put their names forward but wouldn't like to be known, which is fine. One says that she's 49 years old, she suffers from constant bleeding as a result of her fibroids that have been diagnosed 3 months ago. She cannot have the Mirena Coil inserted. That would have been her preferred method of treatment, because it has fallen out in the past due to the amount of bleeding that she has had. She obviously feels tired and lethargic. Her gynecologist has given her the option of Zoladex injection, which is probably what you were going to discuss next.
I mean, things are slightly moving ahead. Zoladex is one of the options, but in recent years we have started on ulipristal acetate, which we call sperm is called selective progesterone receptor modulator.
Okay.
There is a lot of debate about it. It was recently withdrawn because of some scare that it is affecting liver functions, but it is back in the market. They have retested it. And a lot of people are using it. I mean, it is not something which will completely eliminate the fibroid. But imagine that a woman is a very interesting question, which I will ask you. So it is just to judge a female, not a doctor. What do you think average woman bleeds during a period? What amount? What milliliters, if you have to say? What's the average loss in a normal period?
In an average loss, I'm guessing probably between 80 to 120.
Fantastic. So just for our listener, a glass of water is 250 mils.
Yeah.
Whenever I ask my patient this question, that what do you think? Do you bleed a glass of water, or do you bleed 2 glasses, or a jug of water, which is 4 glasses? The average is 2 glasses to a jug.
Okay.
While actually the heavy top bit of a normal period is half a glass.
Yeah.
So that
I was right.
You were absolutely right, because you have read it.
Well, actually, I have read it. So yeah.
So that is the thing. So fibroids, if we say that someone is having half a glass of bleeding, and then with fibroid, it increases to 2 glasses of water.
Yeah.
And giving them medication, we drop it from 2 glass to 1 glass, they will be very happy with the results.
Of course.
So ulipristal acetate is known to improve the, reduce the size of fibroid by 20 to 30%, and improve in bleeding from 50 to 80% in certain patients.
Wow.
And these are just 1 tablet every day, 5 milligram. Now the new protocol is that we do liver function tests before starting it.
Okay.
And they can take regularly this tablet, and every month we do their liver functions, and they can have it in cycles. So it is proven to be, they have done 2 trials on it, which is called Pearl 1, Pearl 2. If you are interested, you can read about it.
Okay.
And it is very, very effective.
Okay. So how many days are we actually giving the ulipristal for?
As long as you want.
And how many days for per episode? So is it for 21 days and then leave 7 days to have a breakthrough bleed?
Continuously, you have to do liver function test before starting. If the liver function test is fine, you give it for a month.
Okay.
Then you check their liver function. If it is normal, you continue for another. So you can have 3 months, 1 cycle. Then you can, if you want, you can give them a break for a month or so, and then you can start the cycle.
So what about the women that ask about whether they are going to have a regular cycle in between taking this ulipristal? Will that be the case?
Usually the people who comes, because fertility will not be the issue.
Sure, it's the bleeding.
It is the bleeding. So they want the bleeding to be corrected. So for them, any day without bleeding is more beneficial than saying we want regular bleeding.
Yes, yes.
So the aim is actually to cause a state of menopause, not actually state of menopause, cause a state of menopause bleeding wise.
Right, I understand.
Talking of GnRH, which is Zoladex,
Yeah.
it causes actually menopause. So it's not only the bleeding stops, but they go through a phase because the ovaries are completely shut. Hence, they are having the hot flushes, they are having the night sweats. So all that miserable things start happening, which is too much for certain patients to take.
Yeah.
And as a result, and not only that, it affects their bone mineral density. So Zoladex, you can give it for 6 months. And then if you have to continue, you have to add Tibolon or anything to protect their bones. So it's not a long-term treatment, while ulipristal you can take for longer duration.
Okay, yes, that sounds very promising. I have a question here from a Sister Isa, who said that I've been diagnosed with fibroids. I have a large fibroid. However, because of the position of the fibroid, my gynecologist has said that it is not preferable to have this excised. I'm not in favor of having a hysterectomy. She's talking about the embolism procedure. How effective is having an embolism treatment to prevent my symptoms of fibroid growth and bleeding?
I think the better thing is, let's talk about the treatment options.
Okay. And
we can go one by one. And how much time we have?
So we have, it's about 48, so we're approaching sort of 50, so there's 8 minutes.
Okay, let's divide it a bit quickly.
Okay.
So first, as your first listener said that she couldn't have coil. So NICE, National Institute of Clinical Excellence, says to put the Mirena Coil, if the cavity is fine, is the best treatment.
Yeah.
Because it is proven to shrink the size of fibroids, it's proven to help with the pain and improve the bleeding.
Yeah.
So if someone can't have it for many reasons, whether they don't like it or the cavity is distorted, we can't fit it, then we go to the next level. Next level is you can give them oral contraceptive pill. So giving them pills, whether it's a progesterone or combined, you can regulate their bleeding.
Okay.
And that can help in shrinking the size of fibroid to a certain extent.
Okay, okay.
So that's the second one. Then we go to the surgical, or before surgical, as we discussed, ulipristal or GnRH, which is Zoladex injection. But they have their own merits, as we discussed. So rather than going in their detail, let's go to the next level, which is the surgical level.
Okay.
So nowadays, science and even physics has made a lot of new advances. One way is, as we said, fibroids are of 3 types. One which is in the cavity, one in the muscle, and one is outside.
Sure.
So the one which is protruding in the cavity and one which is protruding outside the cavity. In the cavity, you can have a hysteroscope, which is a camera going in.
Okay.
And like we remove polyps with the same hysteroscope, it's a resection of fibroids. We can resect the fibroids.
Sure.
And recently, the best advance I've seen is, which is I think quite expensive because each procedure will cost around £1,000. But in near future, that will be coming up. Is a special thing which measures the size of fibroid. It's a new instrument. Normally, we do a scan from the tummy or from the vagina. So this new instrument actually goes in the womb. So very close to the fibroid, it scans accurate size of fibroid.
Yeah.
And then we can inject certain knives which cut around the fibroid and get it out.
Amazing.
Which is very amazing, but it is in very less centers and usually people are doing privately more.
Yeah.
The commonest what we do in hospital is still going with the instrument and seeing it through the camera and then gradually cutting and taking it out.
Okay.
The fibroid, which we call it intramural or not intramural, yes, these are the ones which are falling into the cavity like the pedunculated. So fibroids are divided into 7 categories. So fibroids of category 0, 1 and 2 protruding into the cavity can be removed by this way.
Wow. Okay.
Which is hysteroscope, camera and cutting them out.
Okay.
If this listener of yours has got this type of fibroid, it can be cut or eliminated by this way.
Okay.
Second is the fibroid which is in the muscle bulk. These you cannot cut and remove because they are in the muscle. These fibroids, the treatment would be reducing period. If you want to reduce the period, you can burn the lining of the womb.
Okay.
This is called endometrial ablation.
Yeah.
Help in reducing their bleeding by ranging from 30 to 80%.
Wow. Wow. Okay.
Now, coming to the fibroid, like if there's a big fibroid, it's causing pressure, it's causing heavy bleeding. Then we come to this uterine artery embolization. Embolization is we block the vessels because we remember in human body, any structure which is surviving, which is growing, needs blood circulation.
Sure.
That's how they are fed. So uterus is supplied by 2 arteries, uterine arteries, and then special branches from the ovarian arteries also. So what we do, the main artery is the uterine artery. Nowadays it is MRI guided, but there is also ultrasound guided, which they go through the femoral vessel, the uterine artery, and then these are inert particles which we inject, and they block these vessels. When they block these vessels, these fibroids are not fed any more blood, and they shrink, and they die.
Right. Okay.
Wow. The effective is again, it is effective 60 to 80%. It's only done in certain centers in the UK. It's getting more common.
Yeah.
It has its own merits and demerits, its complication and everything. So when a patient chooses, they go to that center, they select the patient appropriately, because if the fibroid is pedunculated, which is it is like a grape hanging inside or outside, do this procedure, these fibroids, yes, they die, but they break and fall either in the uterus or fell in the tummy, which causes a potential risk of infection or pain.
Yeah.
It is very important that they go to specialized centers where they choose the patient appropriately.
Wow. Okay.
That is one of the modalities that we can do.
Wow.
Then the last and the least are taking the fibroids out. So we go open the tummy, myomectomy, which is taking the whole of the fibroids. So 1 or 2 fibroids, we can do that. But if someone has got multiple tiny fibroids, very difficult, like we are picking up the seeds.
Yeah, yeah.
possible for those patients. But 1 or 2 big fibroid, that is one possibility.
Yeah.
And it can help in improving their fertility also.
Yeah, yeah.
And it helps with their pain. It definitely helps with their bleeding.
Okay. Well,
And last one is hysterectomy, which is getting the womb out.
taking the uterus out. Well, you know, you finished just on time, 60 seconds before the show is going to end. Mr. Cheema, I'm so grateful to you. You did this in such a wonderful manner. After you're on call, you sacrificed your time for the listeners of Salaam Radio, for myself, your little sister, as I know myself to be for you. So I'm so grateful. I really am.
It's pleasure.
Thank you so much. May Allah subhanahu wa ta'ala bless you, and our du'as are with you, and inshallah we will see you again.
Inshallah.
Thank you. That was Mr. Masroor Khalid Cheema, and join us again next week for Salaam Radio with Dr. Shabina.
Your number one for local, national and